Hello, this is Siddharth Tambar. Welcome to our webinar today, Regenerative Medicine for Arthritis, Tendinitis, Injuries, and Back Pain. Thank you everyone for attending. We'll be starting in a moment. As we begin, if somebody can shoot me in chat just to confirm that you can hear me and see the presentation, that would be appreciated. Thank you. Great. Okay. So here we go. So my name is Siddharth Tambar, physician here at Chicago Arthritis and Regenerative Medicine. Today's webinar, what will you get from today's webinar? So you'll learn about the best available treatments for arthritis, tendinitis, injuries, and back pain that do not require surgery. This includes stem cell treatments, blood and platelet treatments, prolotherapy treatment, what is legitimate and not legitimate in the field of regenerative medicine, how to choose the best physician and clinics for regenerative medicine, and how to avoid maybe people that are not quite as on the up and up. I'll be talking for about 40 minutes or so. Along the way, if you have questions, please leave your questions in chat. I will answer as we go along. I'll pause every so often, and I'll leave time at the end as well to answer questions also. Wonderful. So, big question. What would you do if your pain was controlled? How would your life improve? What exercise would you restart? What activities with family and friends would you participate in? So who am I? My name, again, is Siddharth Tambar, physician at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in image-guided musculoskeletal injections. I've been in practice since 2008, practicing regenerative medicine since 2008, as well as rheumatology. And I've been in the Regenerative Network, which is the largest network of physicians who are involved in regenerative medicine in the world. I've been working with them since 2012. So my journey into regenerative medicine, essentially I got interested in this because of my own shoulder. I had started learning about diagnostic musculoskeletal ultrasound back in 2007 or so, 2006, 2007. At around the same time, I used to play tennis when I was a teenager, and I'd stopped for about 18 years and picked up again in my mid-30s. And I'd had a small amount of pain in the right shoulder from playing tennis again. And with musculoskeletal ultrasound, I had found that I'd actually had some chronic injuries to the rotator cuff and ligaments. And as I started to get more interested in tendon and ligament injuries, I started to realize that there really weren't a lot of great non-surgical treatment options. And that was very frustrating to me. And in my sort of journey to find options for my own shoulder, I kind of ran upon regenerative medicine back in 2008. Originally platelet-rich plasma, and as I started incorporating that with my patients, eventually I started including treatments like bone marrow-derived stem cells as well, and those combination of treatments, along with entering into the Regenerative Network back in 2012, has become a significant part of my own practice. So traditional care for tendon injuries, ligament injuries, sprains, arthritis, joint pains, back pains, is very much traditionally just mask the pain, something to sort of tamp down the initial inflammation, and you're really just eventually waiting for surgery. It's a very bad model of care, and it's something that we don't do in anything else in medicine, meaning in other parts of medicine, if you have something like high blood pressure, you don't wait until you have heart disease or your first stroke before you do something about it. You actually try to treat it beforehand. And for some reason in musculoskeletal medicine or orthopedics, it's very much waiting until your issues get so bad that you have no choice but to actually require surgery because your condition has advanced too far. That's a terrible form of care for most things in medicine, and regenerative medicine is meant to really fill in that gap. So problems with traditional care: pain medications, they don't fix the problem. They do have potential side effects. A lot of your traditional over-the-counter pain medications like ibuprofen and Aleve, if taken in too high of a dosage and too long, do increase the risk of a lot of other significant medical issues. The traditional injections that are used, whether it's steroid injections, which have issues with damaging tissue, or nerve blocks such as radiofrequency ablation, do have kind of issues with damaging tissue and damaging nerves. And so they're not great. They can help with pain, but they're not great in terms of safety for tissue. Other problems with traditional care, again, surgery has a role in the sense that for some things that are too advanced, surgery still makes sense, but they are higher risk. And they do have risks including bleeding and infection and tissue damage, not to mention anesthetic risk. For some surgeries, such as arthroscopic knee surgery, if you already have arthritis, it can actually accelerate arthritis by creating more instability. And many routine surgeries, including knee arthroscopy for knee arthritis, have not been shown to be effective. And so there is a significant range of conditions that many of us have that are really not being appropriately treated. And for those of us that are very hardcore involved in regenerative medicine, we feel like eventually 80% of musculoskeletal conditions can actually avoid surgery, and a lot of those with the help of regenerative medicine. So in searching for better options for my own shoulder and then eventually for patients as well, I started looking for treatments that were low risk or no risk, and that could actually improve the cause of the problem and could give longer term improvement as well. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So at Chicago Arthritis and Regenerative Medicine, we're focused on non-surgical treatment for your arthritis, tendinitis, injuries, and back pain, always starting off with evaluating for you have inflammation, instability in the joint, symmetry issues, neurologic issues, correcting with low-risk interventions, starting with exercise and supplements, and then if not working, then for osteoarthritis and tendinitis, utilizing regenerative medicine treatments. And I'll talk more about that. So regenerative medicine is the process where you utilize your own body to treat arthritis, tendinitis, injuries, and back pain. So the normal healing process, you can take something as simple as even cutting your own finger. When you cut your finger, you have an influx of blood platelets. Those platelets and the growth factors from the platelets help to stimulate your local stem cells, which then helps with the normal tissue repair process. That's a great model of recovery from injury. The problem is that if you have tissues with poor blood supply, such as tendons, cartilage, ligaments, discs, labrums, meniscus, they don't have very good blood flow, which is why when they get injured, they tend not to heal very well. So regenerative medicine is a process where you take those same cells and inject them into tissue that's been damaged to help coordinate that normal healing process in tissues that otherwise would not normally recover very well. So why regenerative medicine? Number one, this really treats the source of the problem, which is normally either chronic instability, chronically worn out cells, or chronic inflammation. These are safer than surgery. They're effective for most musculoskeletal conditions until you get to the most severe conditions. And again, strongly believe that 80% of traditional orthopedic surgery will eventually be managed by regenerative medicine. So how does regenerative medicine work? Really, you're essentially optimizing damaged cellular health of tissue. So if you take a look at a joint or a tendon that's been chronically damaged, what you find are cells that are no longer functioning very well. They're no longer pumping out the right proteins, growth factors, and you end up having chronic inflammation. So what our goal is to inject cells that, whether it's your own platelets or your own bone marrow-derived stem cells, into an area where the cells are damaged, to either get those cells to start working better or to actually replace those cells and create a tissue and overall joint that is healthier and optimized. In addition, by treating all the supportive soft tissue structures around the joint, you can actually improve stability as well. By strengthening those supportive structures, including ligaments and tendons, you can create an overall joint and functional unit that is healthier, which leads to less pain and better function long-term as well. So we know that by injecting your own stem cells into a joint that's been chronically injured or inflamed, you can actually help to reduce the overall inflammation in that joint. In addition, you can also treat the nerves that have been chronically irritated. By doing that, by actually reducing the irritation around the nerve, you can actually reduce inflammation, reduce pain, and improve stability in tissues like the spine as well. Great. I just want to address a couple of the tissues that people had, or questions that people had. Somebody asked about physical therapy before treatment. I always think maximize your conservative options before doing anything, meaning if you haven't done physical therapy yet for an injury or chronic arthritis or tendinitis issue, absolutely do that. Certainly, I think if you're working with a physician who specializes in musculoskeletal care, they should help to guide that by working along with your physical therapy, for sure. Absolutely. Somebody else had asked about utilizing these kind of treatments for ankylosing spondylitis. Ankylosing spondylitis is a condition where the immune system is overly active, miscommunicating, and actually causes inflammation in the joints. So what my general approach is, if you have a condition that is driving your problem, treat that condition. So in something like ankylosing spondylitis, you may need medication, you may need to make dietary changes, supplements, things to treat that overall inflammation. If you still have pain or dysfunction after reducing the inflammation, then these kind of treatments using your own platelets and stem cells can still be helpful. Absolutely. Great. So like I said, my journey in regenerative medicine really started by getting interested in platelet-rich plasma and prolotherapy for my own shoulder and other patients' arthritis, tendinitis, eventually incorporating bone marrow-derived stem cells, joining the Regenerative Network in 2012, and also adding in some of the other types of regenerative medicine treatments, including amniotic cells and fat cells as adjuncts to our main treatments. So regenerative medicine basics. Is this legal, right? That's a big question. There are definitely some regulatory issues here, and the answer is yes. It's legal if you follow the law and the regulations, right? That means there are strict guidelines from the FDA. Number one, you have to use your own cells, living cells, not somebody else's living cells. The cells cannot be significantly altered or adjusted. They have some very specific rules on that. And they should be used to inject into damaged orthopedic tissue, not into other conditions. So I'm focused on musculoskeletal conditions. If you've got heart, lung, kidney issues, liver issues, neurologic issues, that is not my expertise. And frankly, the FDA is not very sanguine on those kind of treatments right now with these kind of treatments. So another question that comes up frequently, if I'm older, should I use someone else's cells? So you may see a lot of marketing out there for people that are utilizing amniotic stem cells. The simple answer is no. And the reason why is for most orthopedic conditions, there is good evidence that using your own live cells, your own platelets, your own bone marrow is effective. Number one, there are additional risks if you use somebody else's living cells, namely rejection, meaning your body can react to that. It can develop something called graft versus host disease. So there's definitely risks with that. Also understand that in the United States, it is illegal to inject somebody else's living stem cells into yourself, with the exception of certain childhood leukemias. So the amniotic and umbilical cord treatments that you may see advertised on TV and a newspaper, those are in fact using dead cells. The way that they acquire them is after a baby is born, they take the remaining tissue, they send it to a company that processes that. They process it by basically pulverizing it, gamma radiating it. They kill off all the cells. They make it into a powdered form, which then gets put into a glass vial and then shipped to a doctor's office. That can sit in the doctor's office for up to 2 years. When they need to reuse it for a patient, they end up putting water into it to rehydrate it and then re-inject it. Multiple organizations have looked to see, does this help? Or are there any living cells in it? It can help with pain because there are growth factors in it, but there are no living cells. So that's why it's allowed to be used in the United States, because there's no living cells in it. And that is different than, let's say, using your own cells where the cells are alive. Is there an age limit? For the most part, no. So the results for knees, lower back, shoulders, elbows, ankles, and neck are not impacted by age. The one exception is if you have hip arthritis, and age over 55 does generally portend a worse outcome, meaning the chance of getting a good response from these treatments if you have hip arthritis and you're over 55 is not as good. I've seen some good results, but it's generally not as reliable. What kind of physician does these kind of treatments? I'd recommend the following. Number one, a physician focus on musculoskeletal conditions. If your physician is treating heart disease, diabetes, erectile dysfunction, is doing dermatology, skin-related issues, they're not focused on musculoskeletal conditions. You want to follow with someone who's an expert in their field. And that's how medicine works. Number two, they really should be focused on non-surgical treatments. I have orthopedic colleagues who are very good at the surgical aspect of what they do. They don't have necessarily the same skill set when it comes to image guidance or even experience with using these kind of treatments. And to me, a proper regenerative medicine expert is someone who has a really thorough understanding of what's involved here, which I'll talk about. Can these treatments help if I've already had surgery? Depends, but for the most part, yes. The exceptions are if you've had a joint that's been replaced. If the knee has already been replaced, you've got metal in there, you obviously would not inject cells into a metal joint. That doesn't make sense. But if you've had, let's say, knee arthroscopy or rotator cuff surgery and you've got persistent issues, then these treatments definitely can help. Lastly, my general rules, if you do actually need orthopedic surgery, is number one, if you can keep your own anatomy rather than plugging in metal or plastic, always preferable, although sometimes that's not possible. Number two, avoid surgeries that are really just cutting out tissue, like knee arthroscopy if you have arthritis. It just makes a more unstable joint. And always consider regenerative medicine treatment option if you have been recommended surgery in case you're a candidate for that. So I think really the keys for regenerative medicine are three things. And I'll show some images, I'll show some cases as we go along. Stability or prolotherapy, orthobiologics, and interventional orthopedics. So prolotherapy is this concept, or stability is this concept based on tensegrity. Tensegrity is this concept that comes from architecture, which says that under compression, if you take individual units and put them under compression together, you can get a overall structure that is stronger than the individual units. So that works in architecture. There's this concept called biotensegrity. That same idea works in biologic tissues as well. Key. Why is that key? Because if you look at, let's say, a knee joint, it's not just cartilage or joint that gets injured or painful over time. It's all the other surrounding structures that drive pain and instability as well. And that includes the meniscus, the tendons, the ligaments, the myofascial tissues, the fascial layers, the small peripheral nerves, even the skin. All those things together create that overall functional unit. So prolotherapy is something that's been around for decades in the world, where you're essentially injecting a mild irritating solution like dextrose or sugar water into a ligament or tendon or muscle, and it helps to strengthen the supportive tissues. And it does that because it creates a mild inflammatory reaction, and that's the body's normal way of healing. It's a slow process, it's mild, but it's really the original orthobiologic. All the other treatments that we use, including things like platelet-rich plasma, bone marrow-derived stem cells, they're based on that concept of care. And so the key is, if you need to get something treated, you're treating not only the tissue that's been damaged, you want to treat the tissue around it that offers stability and even above and below it. And so one thing that I see from some of my colleagues is if somebody has, let's say, a knee problem, is that they're only injecting cells into the joint. They're not treating all those other tissues. And sometimes that's why people don't get as good a result as they should. Right, so there's layers and depth to treatment, strengthening and supporting tissues long-term. This leads to progressive strengthening over time, and it also gives longer lasting results compared to some of the other traditional treatments that are used. It's a case study of someone who had lower back pain. This is a 71-year-old man who'd actually had surgery. He had a couple surgeries already called laminectomy. In his case, he was still having chronic back pain, which is pretty common in lower back patients. And so in his case, we had utilized a treatment called platelet-rich plasma to treat his lower back, including treating the ligaments, facet joints, muscles, and the epidural space. His initial treatment gave him about 30% pain relief only. We ended up escalating to a stronger treatment, such as bone marrow stem cells, which then has gotten him up to a 75% improvement in pain and function, and that's been persistent. He's had a long-term result at this stage. So how do you know, one key thing when it comes to regenerative medicine, how do you know you're dealing with someone who knows what they're doing? Number one, they understand that these treatments take time, that this is not a quick process, that this will take several months to really get the best result. They understand that concept of treating the whole structure, not just that one area that's been damaged. They also understand that multiple areas need to be treated and that frequently multiple treatments need to be done, mainly because we know that if you repeat treatment, people tend to do better over time. And also they tend not to offer treatments that may damage tissue, like steroid injections. The flip side is maybe people who don't have as much experience with these kind of treatments, physicians, they're focused on short-term progress, looking to see if you're feeling better after 2-3 weeks, which is not accurate. They are only treating one area rather than the whole joint or structure that needs to be treated. And they may be frequently recommending other treatments up front that may have more risk of damaging tissue and nerves. Orthobiologics. Orthobiologics are essentially your biologic cells and tissues that we inject into damaged orthopedic tissue. Again, it uses the normal healing cascade. You should use your own cells from your own body rather than somebody else's cells, not only from a legal standpoint, but from a safety standpoint. Your own cells, your body is made and primed to use your own cells, not somebody else's. Your body recognizes somebody else's cells as foreign and does attack it. So platelet-rich plasma, after an injury, your platelets are the first cells that are recruited. And when they come into that area, they bring in other cells and growth factors to help assist in repair. You're essentially using focused inflammation to help repair tissue damage. And the growth factors from your platelets help to actually stimulate your local stem cells. That's how they work. So there's a few different types of platelet products that you can make. The picture on the right, you can see tubes of blood that have red cells in it. That's on the right. And you can see tubes of blood that have only yellow cells. Those are cells where we've taken out the red blood cells and all you have are the platelets. So one kind of key thing that you can figure out if you're being treated by a physician is, do they understand that difference? The cells on the right that has your red blood cells are more inflammatory. That can help for muscle issues, but you don't want to be using that in joints and tendons. What you want to be using are the cells on the left that is more amber or yellow colored, where you've taken out the red blood cells. If your physician is really doing one-size-fits-all treatment, meaning you're getting the same treatment as the next person and the next person, that's the wrong way to do it. Rather, the right way to do it is to really pick a treatment regimen that fits you. So platelet-rich plasma is the use of platelets in very high concentration. We use that for joints, tendons, and ligaments. Platelet lysate are taking your own platelets and just cracking them open and taking the growth factors. That's less inflammatory. We generally use that for nerves. Great treatment for nerves. So this is a case study. This is a individual that I saw a few years ago. He is a 45-year-old man. He's a cyclist. He'd been referred to me by a sports medicine physician for patellar tendinitis. He'd done all the traditional treatments, physical therapy, activity modification. On the right side, this is his patellar tendon. The tendon is here. This is where it inserts. There's a lot of tendinitis here. This is the patella here. And this was not getting better with just conservative care. So what we did was a platelet-rich plasma treatment, which turned out like this. Essentially, we did platelet-rich plasma treatment ×2 for him, and he's had a really great response. The picture on the right, again, this is the tendon insertion. This is the bone where it inserts, and this long needle-like structure is the needle under ultrasound guidance, injecting right into the patellar tendon. He had a really great response. And he was actually back to full capacity after that treatment. He actually came back in a few years later, where at that time he now had a hamstring injury. And again, we treated that with platelets again, and he's again back to his normal physical activity. So important for your physicians who are doing this to understand that they need to understand the difference between the different types of platelet preps that are out there. They need to understand that your condition needs a very specific set of recommendations, meaning it should not be the same thing that they're doing for the next person. It should be very much personalized to your issue. On the other hand, if your physician doesn't understand that difference, that it needs to be personalized, they may not be really an expert in this kind of medicine. And in addition, if they don't understand that platelet-rich plasma that has red blood cells or bloody PRP versus amber PRP, if they don't understand that difference, that's another key of figuring out that they're not really an expert in this. So the other type of orthobiologic that's commonly used are stem cells. It's a main cell that drives tissue recovery after an injury. Again, use your own cells rather than somebody else's cells. In the United States, that's the only option. And in the United States, the only legal way to get your own stem cells, live stem cells, is through a bone marrow aspiration from the back of your pelvic bone. That's legal in the United States. That's what the FDA allows. Fat stem cells are not legal in the US. You can use fat as an adjunct, as for structural support. You cannot use it as a stem cell treatment, however. And the reason for that is the cells, in order to isolate them, you have to actually use an enzyme that's not exactly safe in humans. And so the FDA is not very much in favor of that right now. You may hear about umbilical and amniotic stem cells. As I mentioned before, there are no live cells in that. They can still help because they have growth factors, but there are no live cells. I've also heard of people using IV stem cells, no proven benefit for orthopedic conditions. May help for things like hearts and lungs, but again, I'm not an expert in that. If you need it for shoulders, back, or knees, you should have that injected directly into the joint. Stem cell treatment outcomes. So you can help treat, even in advanced cases, you can improve pain and function. So somebody had sent me a question right now asking, hey, can this help if you have severe arthritis in the ankle? You can, right? And the reason why is because, number one, you can reduce inflammation long-term. Number two, you can improve stability long-term. You can take cells that have been chronically damaged in the joint or tendon or ligament and actually get them to start functioning better to create a more optimal joint. You can improve exercise tolerance as you help to create a more stable joint. Can you improve how that looks on X-ray or MRI? If you have an advanced condition, unlikely. If you have a tendon tear where the tendon is not fully pulled apart, yes, you can improve that. If you have a ligament injury, yes, you can improve that. If you have swelling in the bone in an arthritic joint, yes, you can help with that. You can also help with a condition called avascular necrosis. But really, we're more focused on improving pain and function. The reality is that most of our patients who come in are not coming in with a early or mild condition. They're coming with something that's a bit more advanced. And those kind of things can still improve in terms of pain and function. Can we treat bone-on-bone arthritis? So bone-on-bone arthritis is this really terrible throwaway term that you hear a lot of physicians use. Realistically, if you have bone-on-bone arthritis in the knee, you shouldn't be able to bend your knee. And yet the vast majority of people that have advanced arthritis in the knee can still bend their knee. And part of that is because the knee is a very hardy joint. And part of that is because the term bone-on-bone arthritis is really just a terrible term. It's not really an accurate term with what you see in actual people. And so understand that arthritis is a biologic condition. It's not just a structural condition. And so these treatments that we use, including your own platelets and stem cells, can still help. And so my sense is that if your range of motion is still intact, then you can still get a good response to treatment. So if you have, someone had asked about advanced arthritis in the ankle, if you still have good range of motion in the ankle, you can still respond to treatment. If your range of motion is reduced, I think your chance of getting a good response is reduced, but you can still benefit from treatment. Just you may not get the ideal response, but you can still get a good response in terms of improving pain. Again, caveats to that when it comes to bone-on-bone arthritis. If you have advanced hip osteoarthritis, much harder to treat, and generally you're better off pursuing hip replacement at that point. But I think the expectation should always be focused on pain and functional improvement. Imaging improvement is going to be hit or miss, and in more advanced arthritis is unlikely. So this is a case study for someone who has an ACL tear. So interesting, because it really made me start thinking about some of these soft tissue injuries very differently. So this is a young man, 28-year-old man who presented. He had a partial thickness tear of his ACL. So the question is, can we treat those kind of injuries? And the answer is yes, definitely, if it's partial thickness. If it's full thickness, meaning where it's completely torn, some of those can still benefit, and here's why. So, and this is actually a case study to back that up as well. So in if you have a normal tendon that looks like this, I'm drawing on the top right there, that's a normal tendon. If you have a partial tear, you'll see a tendon that looks like this. That is still treatable by injecting cells into the gap. If you have a full thickness tear, if the tissue is still approximated like this, you can still treat that. On the other hand, if the tear is fully blown out like that, where there's a massive gap, that just requires surgery. Now, post-surgery, injecting your own stem cells into that would be helpful to create a more stronger tissue longer term. But a full thickness tear like this, where the tissue is still torn but close together, can still respond to treatment. So in this case, this is a 28-year-old man. He had an ACL tear playing recreational volleyball, and I saw him 2 months later, and we had treated him with his own bone marrow-derived stem cells. And 3 months later, he had no pain and restarted dynamic exercise. And I'll actually show what those images look like. But this is a X-ray image. This is the kneecap. That's the thigh bone. That's the shin bone. This is the needle going into the knee. You can only do this kind of injection under X-ray guidance. And this is the ACL right there. That's highlighted. That's got a little bit of contrast in it. And I'll show you what that result looked like. So in his case, he had a really great result. Namely, if you look at the picture on the left, this is an MRI of his left knee. This is what his ACL looked like. Very, very hazy, very disorganized. You can't even really make out right here what's going on, because it's likely fully torn but still approximated. It's not retracted. And this is his ACL 3 months later. This is a normal looking ACL now, where it's essentially been healed back together. Has a nice linear look to it. There's still a bit of fluid around it. They're still recovering, but you can tell that that is dramatically better. So this is a case of a gentleman that has a man in his late 50s. He's a contractor. He had a rotator cuff tear and actually injected his own bone marrow stem cells and platelets. The pictures on the left, the ultrasound, this is essentially a tear in his rotator cuff. That's a full thickness tear of the rotator cuff, this black area. It's another view of that. And this is 3 months later after injecting his own cells in. And now you see that this has been filled in. This is really a great result. He's had a great functional result and a great pain result, but he's also had a great image result as well, which is pretty cool. So regenerative medicine experts, number one, they should be legally compliant with stem cell treatments. They should be using all your orthobiologic treatments in a safe and honest manner, meaning giving you an honest expectation of results based on the data out there, and appropriately determining your candidacy based on what we know works and doesn't work. Someone who is not as reputable, they may be using amniotic and umbilical cord treatment, calling them stem cell treatments, which is not accurate because they're not live cells. They're not using proven protocols, and they don't have proven results. Before I go on, someone had a question talking about tingling in the feet. You know, the keys with tingling in the feet are, is that coming from the lower back, or is that coming from something else, right? Is that coming from something like diabetes? If it's coming from the lower back, that's something that can still be treated. If it's coming from, let's say, peripheral neuropathy from something like diabetes, then I don't have as much evidence to say that these treatments can help with that. So it depends on what's causing it. Okay, great. Interventional orthopedics. So interventional orthopedics is a term that is now being used to talk about using image guidance, high-level image guidance to treat arthritis, tendinitis, injuries, and back pain. So in the same way that heart disease used to be treated with open heart surgery, that's now been replaced significantly by interventional cardiology using needle-based procedures. You will progressively start to see the same thing happen in the field of orthopedics. So these are some pictures to show what that looks like. So the picture on the left is a picture of a rotator cuff. This is the needle under ultrasound guidance. and we can inject at a sub-millimeter level exactly where an injury is. That's something you can't do blindly. This is another picture on the right of a shoulder. This is under X-ray guidance. Again, this is the needle. This is the shoulder joint. How do we know we're in the shoulder joint? Well, number one, we can see a little bit of contrast within the shoulder joint. And number two, we also injected his labrum, and that's what this is here. And you can only do that under high-level X-ray or ultrasound guidance. Doing this blindly, meaning just feeling, is not even possible. You're injecting at a sub-millimeter level. You need to use the tools that are available. Again, these are those same cases I showed before. This is into the patellar tendon. This is into the ACL. I tell my patients that if they've been told that their physician can do this without ultrasound or image guidance, for me, I don't have X-ray vision until I do develop that, or until someone gives me a neural link to do that. I'll be using the tools in the office, the X-ray and the ultrasound, to make sure that I can properly treat patients. This is a ankle study case where we had really a nice result. He had ankle avascular necrosis as well as ankle arthritis. It's a 41-year-old man. He's a chef. Left ankle arthritis, chronic inflammation, avascular necrosis. The picture on the left, this white signal here is avascular necrosis. That means that there's blood vessel damage into the bone, resulting in dying bone, essentially, leading to pain and arthritis. He had a stem cell protocol. In his case, we treated into the joint. We also treated into the bone. This is 3 months later. That signal in the bone has resolved, meaning his avascular necrosis has resolved. He's 3 years out. His pain is 95% improved. He is standing on his feet at work. He's a chef. He's standing on his feet for 12 hours at a time. He's doing really well. So, again, regenerative medicine expert. They should be using high-level image guidance for all joint, tendon, nerve, and spine injections, constantly improving their technical skills and tracking the results in a formal registry. If your physician is just blindly injecting you as they're trying to treat you, they're not going to hit the right target. They're not doing this the correct way. If they're not tracking results in a formal registry, they're not doing it the right way either. So regenerative medicine treatments, they offer safe and effective solutions for your pain. Okay, I see another question here. Somebody asking about a hip issue, hip injury after, looks like after some kind of accident and improving with water therapy. That's great. Again, always strongly recommend doing conservative treatments first, including physical therapy. And if that's not adequate, then think about getting evaluated for some of these other kind of regenerative medicine treatments. So, questions that people have. Is this too good to be true? I get that asked a lot. So, the good thing is we have data to show effectiveness. We have data that comes from Dr. Philippe Hernegue from France from the mid-90s, actually, for knees and shoulders. The Regenetics Network has data since 2005. This is a rapidly developing field, but it's definitely not new. I have personal experience since 2008, but there's data that goes even before then. There are right and wrong ways to do this. There are realistic expectations and pie in the sky expectations. I think if your expectations are grounded in reality and evidence-based, then these are great treatment options for people with arthritis and tendinitis. How long do results last? Regenetics has data that goes out to 10 plus years now. And Philippe Hernegue, again from France, has data that goes out to 20 years. What I tell people, however, is be conservative in your expectations. And to me, that means if you have a chronic condition, if you have a new injury, that's something that if we can get you to recover with treatment, you may not need treatment again for many years. If you have a chronic condition, meaning if you've had knee arthritis or ankle arthritis ongoing for 20 years, you've had prior surgery, you've had a couple other things, understand that repeat treatment in the next couple of years would likely be expected for a couple of reasons. Number one, your issue is not fresh and new. It's something that's chronic. It's chronically unstable. We can improve that. But there is chronic stress on that joint, so you may need repeat treatment. In addition, we know that there is a stair-step effect in terms of improvement in treatment. What that means is What you'll see in patients who get repeat treatment is if they're starting at a low level, one treatment will get them to a higher level. If they get a second treatment, it's stair-stepping getting them to a higher level. That's different than, let's say, a steroid injection where they may get immediate results and then it comes back down, they're back to their baseline. What's nice about these treatments is that there is generally that stair-step effect. And the best way to maintain your results long-term are to improve your biomechanics, taking the appropriate supplements, work with physical therapy, and again, repeating treatment is additive to that initial result. Get to cost in a second. Somebody asked about bone-on-bone arthritis in both shoulders. They've had the left shoulder replaced, asking, should they have the right shoulder evaluated before another replacement? I would always recommend that, in large part because you may still benefit. If you have significant arthritis in the shoulder, but the rotator cuff is still good, and you have pretty good range of motion, then that can still respond well to treatment. If the rotator cuff is blown out, if the shoulder range of motion is severely limited, it's going to be harder. I do have cases where people have still responded well to treatment, but it's harder for sure. Okay, somebody asked about cost. So most of these procedures are not routinely covered by insurance. Evaluation is, imaging is, but the actual procedure is not. The exception to that is that Regenetics corporate does have a corporate plan, and there are a small but growing number of self-insured companies, which are most large companies in the country. And these companies are amenable to adding this to their benefit plan. It's a process to get it added to company benefit plan, but Regenetics corporate is skilled in doing that. And in some cases, these procedures are covered. In addition, while regular Medicare does not cover these procedures, there is one government that currently covers, and that is TRICARE. They cover PRP for some conditions. They don't cover stem cells. But for some conditions, they do cover PRP. So it depends on your insurance, but the vast majority do not currently. Cost estimates in the United States, this is generally what you'll see around the country. For prolotherapy treatment, expect $650 as a starting point. For PRP, $1,500. And for stem cell treatment, $7,500. Keys to determine value that I'd recommend you think about are, number one, is your physician and the clinic, are they regenerative medicine experts? Number two, are they using appropriate products, or are they mislabeling things and selling them as things that they're not? In addition, this should be done in the hospital. If you're getting this done this should be done in the office, rather. These are safe to be done in the office. If you're having this done in the hospital or in the surgery center, number one, that doesn't need to be done from a safety standpoint. And number two, from a cost standpoint, you'll have dramatically higher facility fees if you have it done in that kind of facility, which will drive up your costs as well. It's another question. Somebody saying issues with their hips. They've seen the orthopedic surgeon. Did have their hip replaced, partial success, now valuing the lower back. It's not surprising, right? I mean, when you take a look at hip pains, the things that you need to think about when it comes to hip pains include, is it truly coming from the hip joint? Is it coming from the SI joint in the back, or is it coming from the lower back? And it can be hard to figure that out sometimes. And sometimes it can be from all three. So what I've seen in patients, I have a couple of patients who actually had their hip replaced and they still had hip pain, and it turned out to be coming from their lower back or their SI joint. That's not uncommon. The other thing is that a portion of the pain could be coming from the hip, but a portion could not be coming from the hip. And sometimes it's worthwhile to treat both areas to see if you can get the whole area improved by treating kind of the whole functional unit, meaning the lower back and the hip. So in this person's case, he's asking, he's had his hip replaced. He's still having some pain. It might be coming from the lower back. He's thinking about getting another surgery. I would strongly recommend, especially for the lower back, which is very amenable to treatment, I would definitely recommend getting evaluated to see if a regenerative medicine process would be helpful, in large part because if you do this properly, yes, it can definitely be helpful for treating not only the lower back, but also the hip pain. But it is a big deal to get another surgery. whether that's a fusion surgery, laminectomy, whatever they're doing, it's a big deal. And a lot of these treatments are still effective and definitely helpful. Great. So as we're starting to get to the end of this, as a reminder, Chicago Arthritis and Regenerative Medicine focus on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain, starting with conservative treatments and then progressively getting to more aggressive treatments as needed, using the highest quality products for your condition, plan that is specifically tailored for your condition, using cells delivered with the highest level of skill and expertise with image guidance as well. Part of the things that I think it's worthwhile mentioning that I stand for, and certainly my organization does, is principles that start with how we do everything here are integrity, respectful, and collaborative care. I think it's important for patients to understand what are they getting themselves into and what are the real risks and benefits. Transparency in terms of candidacy for treatment, transparency in terms of cost, offering the best options available all the times, not just what's convenient, and always doing what's best for the patient, treating them like they're your own family. How do you get evaluated if interested? Popping up on your screen should be a way to click to schedule. We're available to help out either in person or via telemedicine. And if you have additional questions, we are available to answer either now or via email or phone call anytime. I think a large part of this is education. And, if you have additional questions or if you'd like to be evaluated, let us know. And we're here to help and for you. Thank you, everyone, for your time. I'll leave this on a little bit longer, like maybe a few more minutes, and then we'll turn it off. You'll get an email giving you the option of watching this again if interested, and again, available to answer any additional questions anytime. Until we connect again, have a good day and live well. Bye-bye.